Hi, I'm Brendan Everett. I'm a cardiologist at the Brigham and Women's Hospital in Boston, and I was the co-chair with Dr. Sandeep Das from UT Southwestern of the 2018 ACC Expert Clinical Decision Pathway on novel therapies to reduce cardiovascular disease in patients with type 2 diabetes. I'm here today with Jim Januzzi.
Yeah, hi, I'm Jim Januzzi from the Massachusetts General Hospital Cardiology Division. I'm the chair of the task force on expert consensus decision pathway documents and was also on the writing committee for this very important document.
So today we're going to go through a number of key points from this document, and Jim and I are going to give you some context and hopefully some information that you may not get just from reading the document about how best to apply this potentially in your practice and with your patients.
So, I think it's important to emphasize for all of us as cardiovascular specialists that the diagnosis of diabetes mellitus is present in up to 50% of our patients. It's an exceedingly prevalent diagnosis. And then if you go below the surface and think about the fact that an exceedingly high number of patients actually have pre-diabetes, it gets even larger in scope in terms of the issue.
So why don't we move directly then, Jim, to the first point. Most morbidity and mortality in type 2 diabetes come from macrovascular events. Hence, the cardiovascular specialist has a key role in optimizing these patients' care.
Yeah, I'd point out once again that the simple fact is that if we're looking for a place where we can find patients with diabetes, it's in the cardiovascular space. It's in our offices. And so a good understanding of the diagnosis and how to well optimize management for these patients is so critically important.
I think to that point, I think a lot of us spend a lot of time and effort treating patients with diabetes and cardiovascular disease, focusing on their lipids, on antiplatelet therapy, on their blood pressure. And it's very exciting that now there are a number of different agents that are available that can directly address cardiovascular risk in patients with diabetes, some of which we hope to discuss today.
Yeah, no, absolutely. So another important point to make is because of the fact that we see these patients and we have these potentially really beneficial therapies in our armamentarium, the cardiovascular specialist is well positioned to address three key areas in the management of patients with type 2 diabetes. Number one, of course, is identifying or screening for the presence of type 2 diabetes in their patients with or at high risk for cardiovascular disease. Aggressively treating cardiovascular risk factors, of course, something we should always be thinking about. But then lastly, incorporating the data for newer anti-hyperglycemic agents into routine practice. And, Brendan, I mean, in my own practice at the Mass General Heart Center, points 1 and 2, we have typically done. It's really the last part that's new, right?
Yeah, and I agree, and it's the same is true in my practice and certainly for the way I take care of my own patients. I think traditionally as cardiologists, we've stayed away from the management of blood glucose. And as long as medications are seen as being primarily directed at glucose control, we tend to leave those either in the control of the endocrinologist taking care of patients or in their primary care physicians.
Yeah, so it's that concept of the glucocentric view. If we're just thinking about lowering blood glucose, it spooks cardiologists a little bit. But, what can we say about glucose lowering itself with respect to cardiovascular risk? I mean, studies have really been kind of mixed, right?
Yeah, that's right. I think long-term follow-up studies of trials like ACCORD and UK-PDS suggest a modest benefit of glucose reduction. But on the other hand, when you look at, of course, the ACCORD trial had to stop early, where patients who were randomized to the aggressive glucose control arm ended up having a higher mortality rate in the early follow-up of that study, and so it was stopped early for that reason.
And one of the things that we worry a little bit about in terms of the traditional diabetes drugs is the risk for hypoglycemia, which in itself may trigger coronary ischemia and arrhythmia and other things that we try to avoid, but things have changed now. There's been some interesting developments recently.
That's right, and why don't we move then to the next point. Patients and physicians can now choose from numerous medications that have important cardiovascular benefits, in addition to their effects on blood glucose. Patients and providers can choose medications that have demonstrated benefits in reducing heart attack, stroke, and cardiovascular death, as well as heart failure admission, rather than just reducing blood glucose.
It's really interesting. we now have diabetes drugs that seem to, regardless of their really rather modest effects on diabetes, these drugs can actually reduce cardiovascular events. And we'll unpack a little bit on the mechanism maybe in a bit, but it really begs the question, who owns these therapies? Is it the cardiovascular therapist, cardiologist's role to use them, or is it the primary care doctor, the diabetologist? What are your thoughts there?
Well, I think it actually is an appropriate medication a question for patients in 2018 medicine, because increasingly we're using a team-based approach to caring for patients. And I think that these are good examples of medications that have important benefits in domains that are traditionally considered within the silo of the cardiovascular medicine specialist, the silo of the endocrinologist, or the primary care physician. And so I think it's important to figure out a way to use the medications because their benefits are substantial, but you have to do so in such a way that is collaborative and works with the other care providers that the patient sees.
Yeah, it's maybe a little bit of a simplistic example, but I'm old enough to remember when statins were actually viewed as an endocrinology drug, right? Yeah. And with statins, there wasn't as much of the potential changes that one needs to think about if you start one of the newer diabetes drugs. But even still, cardiologists eventually adopted statins into their toolbox and gained comfort with them. With the newer drugs, of course, there's going to come some need for both collaboration with internist diabetologists and also some understanding of how to use these drugs above and beyond simply just prescribing them. But that gets us to our next point, which is that cardiologists have a really important opportunity to play an integral role in preventing and treating cardiovascular disease in their patients with type 2 diabetes. They should consider use of these new medications as part of the armamentarium in reducing cardiovascular morbidity and mortality in patients with type 2 diabetes and established cardiovascular disease in particular. Furthermore, these cardiovascular benefits seem to be clearly independent of their effects on glucose, which is a really important point, right?
Right.
So to some extent, we're freeing ourselves up of the responsibility of managing the hemoglobin A1C.
Yeah, I think that's true, and particularly true from the perspective of a cardiologist, although I suspect that if an endocrinologist were to view these same data, they might feel somewhat differently because of their the centrality of hemoglobin A1C into how they take care of patients with diabetes.
Absolutely, yeah.
I think we'll talk about the individual agents in a moment, but I think one of the key goals of the document that we compiled together was to give a practical guide to cardiologists for how to start these medications, what medications to use, what dose to use, what frequency to prescribe them, what to look out for in terms of potential adverse effects if they were going to use it. And like anything, I mean, there was a time when I didn't use novel anticoagulants in my practice. You sort of have to learn how to use them, and once you become comfortable, it's frankly easier than warfarin, right? Yep. Well, hopefully the same might be said eventually once we become comfortable using these two new classes of medications for specifically, from our perspective, cardiovascular disease prevention and risk reduction in this population.
No, such an important point, right? It takes time to learn these things, and that's really one of the central goals of the expert consensus decision pathway documents, is to provide guidance. It's not so much why to do something, it's how to do something, right? And for us at the college, we really feel that documents like this are so important for the practicing physician. One of the things I really like about the document is that it's not just a quick and deep dive into these new therapies, but it really sets a good understanding for the clinician as to the importance of prevention, both in patients with and without established CVD. So we talk about the things that we should be doing already. Right. And then we segue into the novel therapies, and so why don't we talk a little bit about them? I think that, it's a good opportunity.
Sodium glucose cotransporter 2, or SGLT2 inhibitors have emerged as important new oral therapies for patients with type 2 diabetes. Large randomized controlled clinical trials in patients with type 2 diabetes, most of whom also had established ASCVD, have demonstrated that two drugs in this class, empagliflozin and canagliflozin, reduce major adverse cardiac events and heart failure hospitalization. Empagliflozin also significantly reduced the risk of cardiovascular and all-cause mortality. So Jim, let's talk a little bit about what kind of patient might benefit from these drugs, what the evidence suggests their benefits are, and just outline for our audience what might
Sure.
be the,
yeah, I mean,
factors.
it's really quite remarkable, actually. The results of these trials were somewhat unexpected. These studies were performed at the request of the FDA to prove cardiovascular safety of these therapies, and what we in fact turned around and found was a really impressive cardiovascular benefit. And this is not just for empagliflozin and canagliflozin, but we can actually add dapagliflozin to the list now as well with the DECLARE study. So in studies of SGLT2 inhibitors, these patients typically with a cardiovascular disease, but in some studies with risk factors, multiple risk factors. These are patients with type 2 diabetes and this clinical cardiovascular picture with a hemoglobin A1C of 7% or greater, were randomized to either usual care or an SGLT2 inhibitor. SGLT2 inhibitors reduce hemoglobin A1C by less than 1%. So these are not particularly potent hypoglycemic drugs. They typically do not cause symptomatic hypoglycemia unless a person is taking insulin or sulfonylurea. So they're relatively modest in terms of their diabetes effects. They cause glucosuria. They cause us to urinate out sugar if we go above a certain threshold. But what's interesting about these drugs is that they have numerous physiologic effects. They induce a diuretic effect. They cause a natriuretic effect. They lower blood pressure. They actually cause some weight loss, which is sort of nice to see. And they have other off-target effects, including inhibition of some channels in the kidney and the heart that may render the tissues somewhat more resistant to hypoxia, so inhibition of the sodium-hydrogen cotransporter. So there are all sorts of effects of these medications, and interestingly enough, a very rapid and rather significant reduction in cardiovascular events was noted in each of these studies.
Yeah. I mean, I think if I recall correctly, there was about a 35% relative risk reduction for heart failure hospitalization, and empagliflozin had an approximately 40% reduction in cardiovascular mortality, which was striking. And the etiology of that mortality, the exact cause of death in those patients, is not clearly known, but I think it's suspected by many people that it was probably heart failure related mortality.
Indeed, and if you look at the time to event curves in these studies, they diverge so rapidly. One expects that the mechanism of benefit is some kind of acute hemodynamic effect, so heart failure is certainly a leading candidate.
Yeah, and we should mention that there are some potential adverse effects, and you mentioned one of them, which would be hypoglycemia in the context of somebody who's using insulin or a sulfonylurea. Of note, in the document, we give some guidelines for how best to adjust the dosing of those two medications should the patients be on them if you would like to start an SGLT2 inhibitor. Perhaps more worrisome for the cardiovascular practitioner is the idea that there might be an increased risk of amputation in patients with established peripheral artery disease. And that was seen in particular for canagliflozin.
Yeah, no such signal has been seen for other SGLT2 inhibitors really as of yet, but the amputation signal is particularly present in folks who have a history of peripheral arterial disease. It's typically relatively minor amputations at the level of the toe or the forefoot, but even still, it's obviously a complication that we worry about. And so because of that fact, in the document, at least for now, we suggest that empagliflozin is the drug of choice, particularly in patients who have peripheral arterial disease. There are other downsides to SGLT2 inhibitors. They can lower blood pressure. They can augment the effects of diuretics. So if used in a patient who's taking a loop diuretic, it's important to be cautious and lower the dose of the loop diuretic. And because they induce glucosuria, they increase the risk for pelvic infections, yeast infections, urinary tract infections.
One other important point to just mention before we move on to the next class of medications is that it seems that this is a dose-independent effect for both of these medications. And so in many respects, it's a cardiologist's dream. You can start the medication and there's no titration that you have to do after that.
Fire and forget.
Which is great. One last thing that maybe we don't want to delve into detail, but there's promising evidence that there can be improvements in renal function, or at least preservation of renal function and prevention of chronic kidney disease in patients with diabetes with both of those medications.
Yeah, it would be the first therapy since ACE inhibitors to show nephroprotection in type 2 diabetes, and a really important observation that was actually noted in each of the studies, actually, the EMPA-REG outcome study, Canvas, Declare, and now there's a study called Credence, which is with canagliflozin, where we performed a study of patients at high risk for cardiovascular and renal complications. The primary endpoint was a renal complication endpoint, and canagliflozin was so effective they suspended the trial early.
Oh, was that right? They had to stop it early. That's fascinating.
So why don't we move on to the next point? Similarly, glucagon-like peptide-1 receptor agonists, or GLP-1 receptor agonists, have demonstrated benefits for cardiovascular risk in patients with type 2 diabetes. Of the 6 FDA-approved GLP-1 receptor agonists, to date, liraglutide and some other therapies in this class have been shown to significantly reduce cardiovascular events. Available data do suggest the potential for clinically relevant heterogeneity within the class. So it's important to think about this because unlike the SGLT2 inhibitors, where we do see a fairly consistent effect, particularly in heart failure, with the GLP-1 receptor agonists, there's benefit, but it looks a little different. So do you want to touch a little bit on that?
Yeah, I think the agents that we spent the most time looking at carefully when we were writing a decision pathway were liraglutide and semaglutide. And they were the ones that have demonstrated statistically significant reductions in typically atherothrombotic events, myocardial infarction, stroke, cardiovascular death.
Yep.
And now we can add on top of that albiglutide, which was just published after the document was published. Harmony Outcomes came out, as you know, and that suggested a similar benefit there for atherothrombotic events typically. There are other drugs in the class, such as exenatide, which have not shown statistically significant reductions, and so we tended to focus our energies on those that have the significant reductions. Some of these have more substantial glucose-lowering effects than others. Semaglutide, for example, did have a substantial reduction in hemoglobin A1C in the trial where it was studied. And as a result, there was some concerns about potential effects on retinopathy in patients with diabetes. Nonetheless, all three seem to be give you a relatively consistent 15% or so reduction in what we call a MACE event, so major adverse cardiovascular events.
Yeah, so the heterogeneity here is, in the liraglutide study, also known as LEADER, we saw a reduction in cardiovascular death, an effect on myocardial infarction, whereas in SUSTAIN 6, which was semaglutide, it was really driven by reduction in stroke, actually, which is sort of interesting. To see a reduction in stroke, which is part of the triple MACE endpoint of cardiovascular death, MI, and stroke. With albiglutide, which was studied in high-risk primary prevention, there was an impact on the triple MACE endpoint. There are other, as you say, other GLP-1 receptor agonists. You mentioned exenatide, there's lixisenatide, there's dulaglutide, which is very widely used. And so the interest here is to understand if this is a class effect or if these drugs vary. And we don't really know. In the document, we endorsed liraglutide because that's where the best data are.
Right.
That said, as I said, there are some GLP-1 receptor agonists that are quite widely used without these cardiovascular studies completed yet. So time will tell, if we can sort of exchange from one to the next and expect the same benefits. So it's interesting how these drugs may exert their benefits. So GLP-1 binds to a receptor that other incretins bind to, and they're involved in a number of different things, among other things, gastric emptying. They have an effect on release of other hormones within the gut, and so they lower blood glucose, modestly through a number of mechanisms. Because of the fact that they affect gastric emptying, these drugs also induce a fairly substantial weight loss effect because they render a relative anorexia, which is sort of interesting. They, in aggregate, will lower blood pressure as well, similar to the SGLT2 inhibitors. And as you already said, it's really quite interesting. Unlike the SGLT2 inhibitors, where you see a really rapid and profound impact on outcomes, with the GLP-1s, it's later. It's a year after initiating in the trials, which really implies, as you suggested, an effect on plaque rupture, ischemia, coronary events, rather than a hemodynamic or heart failure-based event.
And I think the remarkable thing here is that we're used to seeing the effects and the benefits to be predicated upon their glucose lowering in diabetes, and that's clearly not the case for these medications. I mean, much like the SGLT2 inhibitors, they appears to be independent of their effects on blood glucose.
Absolutely. So the difference between the microvascular benefits of tight glucose control versus the lack of obvious macrovascular benefit, and so this really turns this all upside down.
Yeah, and I think these agents also potentially have important impacts because of their lack of clear effects on hypoglycemia, or at least they tend to not precipitate hypoglycemia, which is something that I think is gaining increasing attention as a potential deleterious effect of aggressive glucose control with other agents such as sulfonylureas or insulin.
In particular, yeah, and so some have queried whether some of the results of these trials can be explained on the basis of less hypoglycemia, which may then avoid triggering of events, but it really doesn't seem that way, because if you compare to a relatively bland but effective diabetes drug like a DPP-4 inhibitor, these drugs lower blood glucose pretty well, but they really don't produce hypoglycemia, and yet when you compare DPP-4 inhibitors to these drugs, you see a clear cardiovascular benefit. Now, the downsides of GLP-1 receptor agonists, I mean, they're a needle. Patients may not like that.
Right. But they can be given, some of them are as infrequent as once per week. So and then I think the other thing that people worry about is that there can, related to their anorexic effect, be some potential nausea, which I think can be a downside for some patients.
It certainly can. There are other lesser commonly considered contraindications, history of pancreatitis, history of thyroid tumors and things like that. But those are the big ones. And so, you're sitting in the office and it comes time to make a decision. So let's move on to the next point, which is in deciding between the two agents, patients at high risk for heart failure and with established heart failure may derive potentially more benefits from an SGLT2 inhibitor with demonstrated CV benefit, whereas those with osteoporosis, prior amputation, severe peripheral arterial disease, peripheral neuropathy, lower extremity ulceration, infections, and advanced chronic kidney disease may have more favorable benefit-risk balance if initially treated with a GLP-1 receptor agonist with demonstrated CV benefit. So this is where the document really unpacks how to think when you're seeing patients and which drugs to use.
Yeah, and I think this is one of those things where as we put it in the document, the patient-clinician conversation is an important one because, as you mentioned just a moment ago, patients may not be ready for an injectable diabetic medication, but they might be willing to take an oral medication. For that matter, there may be very different copays that they have to pay for one medication versus the other. But I think it's hard exactly to tease out which of your patients are more at risk for heart failure as opposed to atherothrombotic cardiovascular events. Of course, there's a broad overlap. Patients are at risk for both. And so I think if your sense, though, is that somebody has had some admissions, for example, for heart failure with preserved ejection fraction, that might be somebody that you would steer towards the SGLT2 inhibitors, whereas if somebody has intractable coronary disease and you're seeing them in follow-up after their umpteenth MI, that might be a good patient to start liraglutide in.
Absolutely, yeah. I tell my patients, I try to tailor the therapy based on their own individual picture. And so, in my practice, what I typically do is I recommend SGLT2 inhibitors quite frequently because, as you know, I see a lot of heart failure patients. But in patients with hypertensive heart disease, valvular heart disease, but not severe obstructive aortic stenosis, for example, where I don't want to drop blood pressure too far. By and large, I think of an SGLT2 inhibitor. In my obese patients patients with atherosclerotic disease, arterial disease, peripheral arterial disease, I'll think of a GLP-1 receptor agonist. The challenge, of course, is when you have a perfect candidate for one or the other and you run up against one of these contraindications. And probably the most frustrating one for me, seeing a lot of patients with heart failure, is the fact that SGLT2 inhibitors have a lower limit for the GFR.
GFR, yeah.
Now, the reason why this is not that they don't work below a GFR of 30 when it comes to, for example, the cardiovascular benefits. And in fact, in the Credence study I mentioned earlier, canagliflozin was studied all the way down to a GFR of 15.
Is that right?
Yeah. The reason why they're not indicated below a GFR of 45 to 60, actually, if it's 60 for Cana, 45 for EMPA, is because their glucose-lowering effects are not as obvious once your GFR is lower. But we're not talking about a glucocentric view here.
Right, right. Yeah, I think that's an important point. And indeed, the patients who have moderate chronic kidney disease with a GFR that's in that range, potentially in the 40 to 50 range, increasingly there's evidence to suggest that they could actually benefit from the SGLT2 inhibitors.
Yeah, very much so. That's a really important point. And indeed, when you start a patient with CKD on these drugs, you actually see an initial worsening of the GFR, but then over time it improves back up to a higher later plateau. Yeah. So moving on to our next point, based on limited data, it appears reasonable to use both an SGLT2 inhibitor, and in the document we recommended empagliflozin for now as the preferred agent, and a GLP-1 receptor agonist with demonstrated CV benefit. In this case, once again, where the data are, it seems, is liraglutide, concomitantly together if clinically indicated, even though such a combination therapy has not been studied for CVD risk reduction. It's a bit of a controversial suggestion.
Yes. Yeah, right? We definitely, I think, went out on a limb here, and I think that this kind of approach has not been studied in the randomized controlled trials that we base the rest of the document on. But there's some reason to suggest that there may be some synergy there, and then patients with advanced cardiovascular disease and diabetes may benefit from both. I think a related question is whether or not your patients have to be on metformin before starting one of these two classes of medication. And most of the patients enrolled in the trials that tested the efficacy of these medications were on metformin, so at least at randomization, 80% or so on average. But clearly there was no evidence of heterogeneity of effect by whether or not patients were on metformin, and by that, of course, I mean that it seemed like the randomized medication would say one of the SGLT2 inhibitors or one of the GLP-1 receptor agonists had the same effect regardless of whether or not the patient was randomized on baseline metformin or not.
That's really an important observation, and it's something that is an increasing controversy within the diabetes community, because we have these two drugs that reduce cardiovascular risk. Metformin, at worst, has a neutral effect. It may actually reduce cardiovascular risk, but the trials examining this question are ongoing right now, and so we won't know. But if it turns out that metformin does not reduce CV risk the way these drugs do, then I think the current articulated clinical practice guidelines may have to change.
Right.
Presently, the standards for cardiovascular care in cardiovascular risk reduction in the ADA documents articulate metformin first. Then these drugs second, particularly for those patients obviously with an A1C over 7%.
Right.
And even that I find somewhat controversial, because if you've got someone with an A1C of 6.8% on a DPP-4 inhibitor and a sulfonylurea, stop both, and their A1C is over 7.
Right. And it seems like you could be better managing that patient's cardiovascular risk with one of these agents as opposed to those two classes.
So Brendan, very briefly, before we go on to our last point, in the document we lay out a framework of when to talk to patients about these therapies.
Yeah.
Any quick thoughts on that?
Yeah, so quickly, I mean, I think the most obvious time is when you have a follow-up visit with a patient in the outpatient clinic. And that's, of course, when the drugs were studied and when the randomized trials were sort of constructed around that particular interaction. We also open the door to potentially doing it after the patient has been admitted for an acute event, an acute episode of heart failure, for example, or an acute episode of an acute coronary syndrome. Increasingly, I've started doing that in my practice, and I think there's pitfalls you have to be careful of in that latter situation. For example, if you're still titrating the dose of furosemide in a patient who is admitted with heart failure, it may be a difficult thing to also add an SGLT2 inhibitor at that time. The renal function may be a moving target. And so you may want to wait in that context till the patient goes home. On the other hand, if you're on a stable dose, you have a patient who adjusts his daily insulin dose anyway based on his blood glucoses, he may be the ideal patient to start an SGLT2 inhibitor, because you can tell him, well, you know, when you go home, watch what your blood sugars are, adjust your insulin dosing accordingly. They will go down on this new medication. And so I think in select specific contexts, it's probably safe to consider adding these medications in the hospitalized at the time of discharge for hospitalized patients. But generally speaking, I think that you'd be a little bit outside of what the established evidence base
How they were studied, sure. Yeah, which brings us to our final point, which is that cardiologists should work together with the patient and the other members of his or her care team to determine whether he or she would benefit from these therapies and to initiate therapy if appropriate. And that really gets to that point of when to start them, how to start them, and in whom should, or with whom should you discuss these the initiation of these therapies. So in my own practice, I tend to avoid initiating in the hospital, in part because of the points you raised. We're often actively diuresing these patients. We've recently started initiating sacubitril valsartan in decompensated heart failure. That has an obvious effect on natriuresis, diuresis, and blood pressure particularly. So I worry a little bit about hypotension in these patients. But I am very aggressive in the office in terms of reviewing the patient's risk. I check A1Cs. I don't know if you do.
Yes.
I check A1C concentrations levels and make the recommendation accordingly. But it's important to, as we say, it's important to involve everyone in the team. And so whenever I evaluate a patient and make the recommendation to start an SGLT2 inhibitor or GLP-1 receptor agonist, I include the primary care doctor in the discussion. I actually call. I don't send it in my note. I don't email. I actually call and discuss. It takes a little time, but I think it's worth it. And increasingly, I'm finding the previous uncertainty about these newer drugs is no longer present, and internists and diabetologists are much more comfortable.
Well, I think, you know, as you know, we worked closely with a number of diabetologists on the writing committee and then had peer reviewers from the ADA, and I think that they were, it was a very collaborative relationship. And so any sense that this might be a way to, as we say, you know, this is a way to, for cardiologists to gain more turf, if you will, is not an appropriate, you know, that's not the way we view it. Certainly, I think it's much more collaborative than that. And I think, you know, ultimately, everybody practices in a different kind of clinical environment. And some people have specific cardiovascular diabetes clinics where they really are managing these risk factors for their patients, and the community sees them as the key drivers of that. Other people operate in a much more sort of a consultative and kind of independent practitioner kind of environment. And there, you know, the phone call and, hey, what do you guys think about this? Can we start this medication is probably the appropriate way to go. And whatever fits your practice model, basically, I think.
Certainly, and I've had clinicians say to me, I love this, I'm going to do it. It's already in my practice. I've had other clinicians say, I've never touched diabetes drugs, I'm never going to touch them. And it's that latter category that I think is where this document is even more important, because we're not talking about treating diabetes here, we're talking about treating the patient with diabetes and reducing their cardiovascular risk.
Yeah, that's right. So just some final thoughts before we close out the video, Jim. I think in particular, these new therapies for diabetes give cardiologists the opportunity to improve the care for their patients with both cardiovascular disease and diabetes. I think it's they're groundbreaking therapies and potentially have important effects for their patients. What they require of the cardiologist is that they extend themselves a little bit, both to review the data, understand the data, and to potentially think about starting to use the medications in collaboration with the patient's other care providers. We think the document offers a practical guide, not just to the evidence, but also to how to implement this in your own practice, what doses to use, what frequency to prescribe them, what drugs to pick, those sorts of things. And we hope that cardiologists within the ACC can begin to see these medications as key strategies for improving the cardiovascular care of their patients with diabetes.
Yeah, I agree, Brendan. And as the chair of the Task Force on Expert Consensus Decision Pathway Documents, I couldn't be happier with the way the document came out. These are really important documents for the practicing clinician, and this one in particular is really groundbreaking with its co-sponsorship with the American Diabetes Association, participation by members of the ADA, along with our ACC writing committee members. This really offers the practicing clinician in cardiovascular medicine new tools for reducing cardiovascular risk. Again, we're not talking about the glucocentric view here. We're talking about reducing cardiovascular risk in our patients with diabetes. And we hope that the viewers here, as well as the readers of this document, will benefit greatly from having a good close look at it.